and good afternoon. Welcome to your darling program, The Spring Clinic, on Western Spring Television, channel 190 Star Times. It's been a while that I have featured on this program because of a short break I had. I am sure that we will soon be having the program without any form of break. The Spring Clinic is a platform where we discuss our health, various perspectives for our health. How do we seek health care? We bring in different kinds of specialists, caregivers, and all of that, so that we will know what to do each time there's a problem. And this afternoon, I have the privilege of hosting Mr. KAYODE. FOLORUNSO is the Chief Physiotherapist, State Specialist Hospital, OSOGBO. You're welcome, sir, Mr. KAYODE.
Thank you very much, sir.
Yeah, it's nice having you here. Apart from being the Chief Physiotherapist, State Specialist Hospital, can you also tell us more about yourself?
I am also the General Secretary, Association of Academic and Clinical Physiotherapists of Nigeria, ACAPEN. The Osun State chapter.
That's a strong one. What is peculiar with that group? What is special with that group that you have just?
Actually, is the umbrella body of all physiotherapists in Nigeria, in which Osun State is a member, and the sole purpose is to provide a platform for all physiotherapists to gather together, promote the image of the physiotherapy as a profession in the country.
That's okay. You're welcome, sir.
Thank you very much.
Yes,
sir.
let's start by, I think you need to do a lot of education this afternoon. What do physiotherapists do? What is that specialty? What is it all about, generally speaking?
All right. From a general perspective, I always tell people, when you say physiotherapy, it's as simple as the name. Physical therapy. Is basically, or let me say from a layman's perspective, it has to do with treatment and rehabilitation of disease conditions, deformities, and injury via physical means.
Oh. So what we are saying is that any form of injury, any form of trauma, physiotherapists can handle it.
Exactly. That as long as it requires physical intervention,
okay,
that is what we do as physiotherapy.
Are you people different from orthopedic surgeons? Because you see, oftentimes, once there's an injury, there's trauma, somebody has a form of a fracture in the leg or something, the first place people go to is to the orthopedic surgeon. So what is the difference? What is the overlap? And how do you people complement each other?
All right. Many a times, orthopedic surgeons, they are trained to manage the fracture directly. Okay. But as physiotherapists, we come in the area of managing complications that may arise from the fracture. So as physiotherapists, we are not involved in managing fracture, which is the primary conditions, but complications that may arise from it.
Okay, so if somebody has, for instance, a fracture and is healing, and the person cannot walk well or something, I'm trying to reason like a layman.
You know, in fracture, mobility is an issue.
Very important.
Or let's say physically the person or the patient is challenged, and the perspective of management is to restore the patient back into full function.
That's okay.
So physiotherapy will come in. We want to maintain or enhance mobility.
Okay.
Apart from that, there are other complications that could also set in from the fracture itself. Okay. Take, for instance, depending on the intervention by the orthopedic surgeon, whether the patient is on POP or a surgery has been done, muscular function is called into challenge. Yeah. So we want to ensure that the muscular function of the patient is preserved as much as possible. Yeah. So these are the aims of management when it comes to fracture.
That's becoming quite interesting. So it's not only fracture that you people are involved in. Please, can you tell us areas of because I'm sure that our viewers at home, they are not so used to physiotherapists, or except for those who have had patients that were referred to you, you know. So this is an opportunity to actually, let's hear more. Certain conditions, very common amongst us, that people don't know that they need physiotherapists for. Please, can you?
All right, thank you very much.
Yeah.
Physiotherapy, like you said at the beginning, is actually a specialty. And there are various areas of specialization in physiotherapy. But majorly, most of the time, what will readily bring a patient into a physiotherapy clinic is pain. So when it comes to musculoskeletal physiotherapy, is a very wide area. We manage pain.
What kind of pain?
Pain from whatever the source. Musculoskeletal injury. Take, for instance, arthritis. That's one of the conditions we
joint.
manage. Yes.
It comes in the joints.
Exactly.
Pain at the joints.
Pain at the joints, whatever the joints, the shoulder joints.
There's this one that is always...
Even at the spine.
Yeah.
We also manage that as a physiotherapist. And primarily what we bring them to the clinic is pain.
It's pain, yeah.
Pain and perhaps deformity at the chronic stage.
Or at times loss of function.
Or loss of function. Thank you very much.
Yeah. Because at times you just feel your hand is, some people are writing and their hand is dead or tingling.
Yes, some of them will complain of numbness. Yeah. Some will complain of paresthesia. Yeah. Some will also complain of perhaps a needle sensation.
Kind of, yes.
Kind
at times it can be scary. Some people think they're already having stroke. Somebody who is not a known hypertensive, at times they say their hand, they cannot move it. Somebody came and woke me up around 6 a.m. one day and said he already had a stroke. I said, how did you know? They took the BP, it was 128, which is a normal blood pressure. But I think invariably what we found out was this thing, is this cervical spondylosis?
Cervical spondylosis.
That's a very common. What is making it common? From your own practice, why is it very common nowadays?
All right, cervical spondylosis. Why is it very, first of all, let's start from what is cervical spondylosis. I mentioned arthritis at the beginning. Arthritis simply means there is inflammation and degeneration of the joint surfaces. And this is not just peculiar to the weight-bearing joints alone, the knee, the ankle, the hip. Even at the spine, arthritis can also happen. The degenerative changes, that is wear and tear of the surfaces of the joint, can also occur even in the spine. And so when this happens, we say there is a spondylosis. At the neck, we call it cervical spondylosis. But interestingly, although age is a factor in arthritic conditions generally,
as we get older, the wear and tear and the cartilages
becomes more pronounced. Exactly.
Yes. But apart from that, what could actually induce this pain in the neck?
All right. History of trauma.
Trauma there.
If there is trauma, previous injury, let's take, for instance, sportsmen. They are prone to all sorts of injuries, not just to the neck, even to all parts of body. So there could be arthritic changes. Not only that, there is what we also call micro trauma. Micro from the name, smaller injury, which in most cases are repetitive. Especially, it has to do with the way we take care of our neck. And even in the case of the low back, the same thing.
What do we do? What can we do to prevent this? What's the best way to sit? Because I mean, I've gone for I think a seminar, I can't remember now, where they were teaching us how to sit. Me, when I drive like this. I have to push my car seat to the back. I don't know, maybe that's how I just got used to driving. And a friend of mine says, no, it's not the way to sit. Is there a particular way people sit that makes them to be prone to this condition?
All right. Let me say this. I was very happy when I came in. I saw the chairs. I said they have ergonomic chairs.
Oh, yeah?
They are back friendly. That is wonderful.
This chair like this?
Yes.
But it's not relaxed.
Maybe because of the height anyway. So now talking about posture. Posture starts, let's focus on sitting posture, which is the problem most of the time. When we sit, the curvatures of the spine must be maintained at every point in time.
Wow.
The neck and the low back are similar. in terms of curvature. They curve inward.
Okay.
When you look at it from the back,
okay,
we call it the convexity.
Okay.
The curvature is convex, looking at it from the back. So this curvature, whether at the neck or at the back, must be maintained at all time. That is the basic principle.
I shouldn't bend to accommodate the curvature.
Exactly. So whatever position that will obliterate that curvature is not good. So when I sit, my spine should be supported in such a way that the low back is this way. And also for those who are office workers, they sit down for long hours, doing one sort of things or the other. It is always advisable for them to be conscious of their neck. So when you want to sit down, they make sure they draw their chairs very close to their table.
So that when they are looking at the screen,
whether the laptop or they're writing, they don't have to lean forward and obliterate that curvature. So that curvature is very important at every point in time, irrespective of our position.
So from what you are saying, I think a good number of these pains that is coming outside of age as a factor are some of the things that are induced as a result of our sitting or management of our posture.
Exactly. It's posture related, or let's say generally is work related. What we do with our body, what we do with our spine.
Some people carry laptop to their bed. There's a way they sit down on the bed like this and still be working on the, you understand? So oftentimes they violate some of these things you're talking about.
Exactly. I may not advise that. We call it laptop. It should be on your lap.
On your lap. Okay.
And when it's on your laps, you are sitting down and you make sure you sit correctly. In fact, the ideal sitting is in such a way that the trunk is at 90 degrees to the thigh and the feet are well supported on the floor. That's why I said the other time when you said you are not relaxed, that perhaps because of the height, your feet are not adequately supported on the floor.
So they need to construct.
So it's not just a matter of the orientation of the trunk with the laps. The feet also must be adequately supported on the floor.
Do you do trainings for a lot of our office people for them to know this? Because I mean, I think if you look at the workplace here, I think our workmen here, their chair is good. Or what do you think from what you saw?
All right, it's still very encouraging anyway. Yes, you know, generally the problem with physiotherapy is awareness. Although as physiotherapists, we are trying as much as possible to bring the information to the people, but I must confess it's an evolving profession.
Absolutely, yes.
And we are still doing our best to make sure that
because mere just sitting down properly can help you to prevent a lot of pains and all of it.
Exactly. If you are conscious of your posture at every point in time, yours sincerely, the chances of you coming to the clinic, I mean, a physiotherapy clinic is very, very minimal.
How do we differentiate this low backache from jedi? Because I see some people, when they are prescribing, you know, all these our doctors on the street.
All right.
Well, some of the things you're talking about seems to be some of the things they say that is jedi and that they treat. What is that thing that they are describing? How does it related to the one you treat?
All right. Thank you very much. That's an interesting question. And each time I am asked this question, is always a source of controversy. In fact, most of the time, wherever I go to talk, we don't really get to conclude the matter. The reality on ground is that medically, there is nothing like jedi. The closest to what people call jedi is hemorrhoid.
Hemorrhoids, okay.
That is the part of the anus
that protrudes
proceeding outside. Yeah, that's what they describe as. Or some would say when they have pain in the low back, they have jedi. Unfortunately, they engage in all sorts of things that could even be hazardous to their system. All sorts of concussions, alcoholic concussions, loading their kidney, loading their liver, which is even more dangerous than the jedi they wanted to treat. So
majority of these jedi people needs to come to you.
Yes, they do.
From what you're saying.
Yes, they do.
You'll be able to.
After they have tried all sorts of things, and it has failed.
That's when they come.
Eventually, perhaps they see their doctor. The doctor may say, go and see your physiotherapist. And you know the interesting thing? Most of this back pain, in fact, about 90% of them, like I said earlier, are related to posture. how we use our back. So even before we go to treating them, merely giving them some ergonomic advice, going on with it, you discover that the pain disappears. And that is the end. And some of them may not even come back to the clinic alone. Just observing those, we call it on program. Go and try this at home. It's like a doctor prescribing medication.
You know, I don't think they believe it. This pain that is almost racking my head, you say I should just go and start sitting in a particular position. They feel, is it going to do the magic?
Yes, they don't. But most of the time,
it works.
By the time they try it, and they see, imagine a patient coming to the clinic, oh, I have pain in my low back, it's so excruciating. In fact, I will rate it 10 over 10. Okay, go and do this. He or she starts doing it at home, and he comes back. The pain has disappeared, or is disappearing, you know, that by now, I rate my pain as 5 over 10 or 4 over 10. That is significant.
Just
so that motivates them to continue and comply with that instruction.
Absolutely. Now, I'm just curious, what is the major form of referral to your unit? What do you think could be done? I mean, like you have also admitted that your discipline, people are not too much aware of what you do, really. Do you understand? The only time people see you work is when somebody has stroke. That's what is in our head, that somebody has stroke. Take that person to the physiotherapist. Apart from that, they feel they don't do what. So what do you think, how do you think referrals can be generated towards your department?
All right. Most of the time, we get a consult from medical doctors. Most of the time, they are first contact. But beyond that, like I said, physiotherapy is evolving. These days, we discover that there are some patients that will come directly to the clinic. And when this happens, perhaps from their previous experience of what physiotherapy has done for them.
Can they come to you directly without a doctor?
Yes, they can.
That have come to see the physiotherapist?
They can. The reality on ground is that physiotherapists are trained to make diagnosis. And when the condition requires referring to other members of the healthcare team, we send our consult.
That's okay.
All right.
Now, I'm just wondering whether your scope of expertise also involves, I want to lose weight. I want to, like our ladies who want to maintain a particular figure.
Okay.
You know, like gym.
All right.
What's the difference between your work and those who work in gyms?
Okay.
I don't know whether you get my point.
Yes, as physiotherapists, when it comes to, we call it fitness.
Okay, fitness, yes.
Yes, physical fitness. And when we do that, we do it from a medical perspective.
Okay.
It is a holistic treatment, holistic involvement.
So you people do fitness too, physical fitness?
Yes.
How is it different from the gyms we go to?
That is where I'm coming to.
Okay.
We want to examine the patient holistically from a medical perspective. Are there things we should watch out for? Is this patient is this client diabetic? Is there hypertensive? There are preliminary tests we would have conducted to actually establish the level of fitness of the patient before coming to us.
Or the kind of exercise you want to take the person into.
Exactly. That's also another issue, because exercises are not just exercises. They are drugs. Just like the drugs medical doctors prescribe. Dosage. They have dosage. They have
because
parameters.
I've once gone for one gym something. I felt the thing was more of punishment than what they were trying to. They took me there. My son said we should go and all that. I think after I went 1 or 2 times, I ran away from the place because they were not ready to listen to me that this exercise you are giving to me is more of punishment than something I'm ready to endure. Yeah. Okay. Although I think you people also induce some pain on people.
No, we don't induce pain.
Or what do you do? Or you
talk to pain.
You talk to pain.
Yes.
But at times in talking to pain, you may take the person through some pain.
Not really. You know, in fact, is one of the precautions in our intervention.
Oh, okay.
Whatever you are doing and it's inducing pain on the patient, you know that's a warning.
That
you want to stop it.
Oh, really?
It's either you are overdoing it or you are doing what is wrong. Take, for instance, we we manipulate joints and spine a lot in physiotherapy. In fact, when it comes to pain management, there is no way we can take manipulative therapy out of it as a form of physiotherapy intervention. But whatever you are doing and it inflicts pain on the patient, is either you are doing the wrong thing or the intensity is too much. So you need to review the dosage is too much.
So let's go back to the fitness, physical fitness.
All right, physical fitness, like I said, exercises, they have parameters. There is what we call high intensity exercise, and there are also what we call low intensity exercise. If the goal of coming to the gym is to strengthen muscle, we want to focus more on the high intensity exercise. That's why you see some clients carrying weights, weighted objects, dumbbells and the likes, barbells and the likes.
You have them in the physiotherapy unit?
Yes, we do have them in various weights, 1 kg, 2 kg, up to as high as the patient can carry.
Walk to your unit and say, I'm here for physical fitness?
Yes, definitely.
Assisted in your specialist hospital?
Exactly.
And said, I've come for fitness?
Yes. We do have a fitness section.
Just like we go to gyms.
Exactly. We do have a fitness section where we see them. But like I said, we attend to them from medical perspective.
I understand.
We want to know what are the underlying conditions, what are the risk factors, what are things we need to watch out for in this patient. So we assess them initially, like even though they are clients, they are not patients, but we want to assess them like every other patient.
Do you have a word for our gyms? People who operate gyms in hotels, just in town, because I think you are emphasizing this medical perspective, and I think it's a very crucial one. Or what do you think?
Yes,
if you have an opportunity to talk to people who own gyms on commercial, level in the town, what word do you want to tell them? You want to give?
I will want to encourage them to ensure that they have a physiotherapist attached to them, or even a medical personnel attached to them. Because the ideal thing is that before any client engages in exercise, he must have been evaluated. He or she must have been medically examined to be fit for whatever he or she is going to do. Yours sincerely, we've had cases of people getting themselves engaged in exercises and suddenly they slump and die. All these could be prevented with adequate evaluation of clients. So the evaluation
involves things like what?
We want to look at their parameters, the vital signs, the blood pressure. Normally when people engage in exercises, the blood pressure is expected to shoot up. So you want to know the baseline level before the person starts. What can the patient do? So the vital sign could also help. The blood pressure, the respiratory rate, the pulse rate, and so on and so forth. Then at the same time, there is also what we call targeted heart rate. At what level do you want this patient to commence exercise? What is his possible maximum heart rate? So we should be able to establish the maximum heart rate and now decide at what percentage I want to start this patient first. Before I gradually graduate the patient.
So you don't just hit the road or hit the gym.
No, you don't just hit the road. It's very dangerous.
And say my friend is carrying 20 kilograms, I'm carrying 10. I'm going to catch him.
Apart from the likelihood of inflicting injury, musculoskeletal injuries, the heart itself may not so much be fit to actually support such a high level of exercise.
There are times one has this, is it muscle pull? We call it as laymen.
Cramp.
What's that thing? Okay, it's cramp, Abby.
Cramp.
And at times it's like you are almost, something is freezing you up. What causes it? And how can it be managed?
Cramp majorly could be as a result of any condition that causes pain. Pain and cramp, they go together.
What's the difference?
Once there is pain, pain is a sensation. There is expected to be a response, especially take for instance a muscular pain. So I would say cramp is the response of the muscle to that pain stimulus.
Okay.
Something is wrong with the muscle. The muscle wants to contract. So there is this sudden cascade of muscular contraction, which we call cramp. Unfortunately, that cascade of muscular contraction itself could be very, very painful.
Okay.
So the more the pain, the more the cramp.
Yeah.
And the more the cramp, the more the pain. If there is no external factor to inhibit it, it becomes a problem. It becomes a complex. More cramp, more pain, more pain, more cramp. That's why you see some sportsmen on the field, footballers especially, they suddenly sit down, and they can't do anything. They hold their legs, especially the back of the thigh, the hamstring or the calf, suddenly contract. And it's very simple. The muscle is contracting repeatedly. Painful contraction. That is cramp. All you need to do is to introduce a mechanical force into it that will inhibit that contraction. And that is why you see even their colleagues, before a physiotherapist run to the pitch to rescue them, raising the leg up to actually stretch it and try to inhibit that contraction. So the moment you stretch, the cramp goes down and the pains disappear.
Thank you, Mr. Folorunso. Now, what are the kind of conditions in your practice that you have seen in Osogbo, for instance, or Osun State? Okay. In terms of the epidemiology of the kind of complaints you have had from your experience here in your clinic.
I'm a musculoskeletal physiotherapist, and I will confess that is on the increase. In fact, if 100 patients come to my clinic in a day, I can assure you about 80% of them are musculoskeletal patients.
Why?
And predominantly arthritis.
Wow.
Pain in the joints and the low back.
What's responsible for this? Can they be prevented? Is it age-related, or is this something we're doing wrong that is causing this?
You are right, sir. It is age-related, even though you still see some younger generations still coming down with these complaints. So it comes to what we do with our body, especially the low back and the neck, which I was trying to talk about the other time. Many a times we neglect our back, we abuse it. We abuse the neck, we abuse the low back, the way we sit, what we carry. All these can inflict serious injury on the spine.
This aspect, I'm sure a lot of viewers at home will be interested in it. So we're going to go for a short break. I have been speaking with Mr. KAYODE FOLORUNSO, the Chief Physiotherapist, State Specialist Hospital, Osogbo. We'll go for a short break, then we'll come back and continue where we had stopped. Thank you.
Thank you, sir.
James Ajibolaige was a lawyer who obtained his first degree in classics from Nigeria's premier University of Ibadan. Born September 13, 1930, the orator and the polyglot spoke impeccable English, French, Igbo, Hausa, and Yoruba languages. His fine diction placed him among classical orators and public speakers like Cicero, the Roman orator. This attribute earned him the prefix Cicero of Esauke. He authored Kaduna Boy, an autobiography, The Teenage Diary, Constitution, and The People, among 6 other books. Bolaige was a colorful politician, elected governor of Oyo State in 1979 and appointed a federal minister in 1999. He was a pioneer founder of ADEFILA, the Yoruba social, cultural, and political group. He invested his political sagacity to propel the group to the height of political leadership and decision-making in the southwest of Nigeria. Bolaige was assassinated on the 23rd December 2001. His murderers are yet to be apprehended till today. Western Spring Television identifies Bolaige as a watershed character in history. Born Jeremiah Onyeni Obafemi on March 6, 1909, Obafemi Awolowo was a prime architect of Nigeria's independence and most consummate advocate of free education and social welfare in Africa's most populous nation. Erudite politician, thinker and philosopher, Awo was fondly addressed by associates and political colleagues, brought his unique attributes to bear on governance in the defunct Western region. He administered as leader of government business and the premier between 1955 and 1958. Obafemi Awolowo's premiership witnessed pioneering in the multi-sectoral policy initiatives and execution. The Western region under his administration paraded several enviable records. First television station in Africa, first real estate in Nigeria, first high-rise building in Nigeria, first modern sports stadium in Nigeria, first agricultural settlement in Nigeria, first modern civil service secretariat in Nigeria, and first industrial estate in Nigeria. His face is on 100 naira denomination as a mark of honor for his distinguished services to his country. Western Spring Television identifies Obafemi Awolowo as a major character in history. Hilas Olayinka Herbert Macaulay, politician, nationalist and journalist, was the first Nigerian to qualify as a civil engineer, surveyor and architect. Born on November 14, 1864, Herbert Macaulay was the founder of Nigeria's National Democratic Party, the first political party in pre-independent Nigeria. Scholars of Nigeria's political history describe Herbert Macaulay as the intellectual bulldog of 19th century Nigerian nationalist movement, in the deference to his qualities as founder and leader of two foremost political parties, Nigeria National Democratic Party (NNDP) and the National Council of Nigerian Citizens (NCNC). His matchless versatility in party organization and control kept the British colonialists on their toes in the entire span of his active life. After his death on 7th May 1946, Herbert Macaulay remains a hero of his country, which recognized his anti-colonial struggles. Today, Nigeria's 10 naira coin bears his oval face and trademark moustache. Western Spring Television identifies Herbert Macaulay as a major character in history.
Yes, viewers, you're welcome. We're at the second segment of our program, the Spring Clinic, where we discuss various medical issues. We bring in experts to help us, to enlighten us and guide us on what we should do when we have issues. I have the privilege of speaking with Mr. KAYODE FOLORUNSO. He's the Chief Physiotherapist, State Specialist Hospital, OSOGBO. You're welcome, sir.
Thank you very much, sir.
I think before we went on a short break, we were discussing the patterns of cases that you see in your unit at the State Specialist Hospital. Can you please build on that?
All right, thank you very much, sir. I mentioned arthritis, issue of low back pain, neck pain, and leaving that area, let's also go to neurological conditions. Stroke is there. In fact, we get to see more often cases of patients with strokes, and interestingly, it also occurs across ages, both the aged and the younger ones. So they also do come down with strokes, and also conditions of traumatic spinal cord injury, injury to the spines, then complications from HIV/AIDS.
Oh, in what way?
And so on and so forth.
How does HIV/AIDS cause a problem that require physiotherapy?
Yes, it's actually an immune problem.
Yeah.
So if it has gotten to the level of one infection, especially the cardiovascular, Physiotherapists could come in to manage patients with such a presentation. Not only that, even physically, musculoskeletally,
yes,
they are also, you see them, they get wasted, and also that tells a lot on the physiological functions of the muscles and the like. So is either we want to preserve it, or we want to maintain it, or we want to improve on what the patient present with.
So what other patterns? Yes, you talk about neurological needs. Yes. Neurological cases.
Yes, among children, we see children presenting with cerebral palsy. Injection palsy is also there. Many a times you see patients coming to the clinic, you see their mother bringing them after receiving injection. We just discovered a few days after, my child cannot move one leg.
Are those ones reversible or irreversible?
Yeah, it is, depending on the extent of the injury.
Wow.
Depending on the extent of the assault. So you should not
just allow anybody to put a needle into your buttocks.
Exactly.
You've seen cases that are paralyzed permanently because of injection?
You know, in injection, we call it injection neuritis or injection palsy, depending on the severity. But we've seen cases of injection palsy. That's why when you see some patients, they have issue moving their foot. They cannot control it when they walk around. We call it foot drop.
Foot drop, yes.
Most likely they have suffered injection palsy at one point in time.
I know in our own field too, you know, where some people just tie psychiatric patients, you know, somebody who is mentally ill, people just get rope, any form of rope, tie the leg, tie the hand, tie him to bed or something, or to a tree. And before you know it, they could suffer a lot of paralysis.
There could be injury to the nerves. And this could lead to paralysis.
So that means there is a lot of caution one has to exercise if you are carrying people, maybe the sites of accident, more like a first aid. What words do you have about to
yes,
say about that?
the common practice when there is an accident, you see people carrying water, pouring it on the victim. So that I wonder the reason for that anyway.
So that something will wake up.
So that something will wake the person up. That is actually dangerous. You may suffocate the person along the line and even kill him before getting to the hospital. The best thing at this point in time is when such happen, you first of all want to move the person out of safety. If it's on a highway, you want to try as much as possible to relocate the person from the point of accident to a safe place. And in doing that, one also needs to exercise caution. Anything could have happened in the course of a road traffic accident. There could have been injury to the neck, injury to the lower back. So you don't want to carry such people anyhow. So in transferring them, it's very important to ensure that the spine is stabilized before moving them.
How do you ensure that practically?
By ensuring that there is adequate support.
That means you carry them flat?
Yes, you carry them. Obviously, most of the time, a stretcher may not be available.
So what do we do? We carry them flat?
As many people as possible should be available to support all the strategic part of the body, starting from the head, the neck, the body, even up to the leg, and move gently to a safe place. Then from there, you may now think of contacting health personnel, most of the time the medics, ambulance response, and whoever, and transport the patient to the hospital.
That's good. Yeah. What other services do you think? You were talking about, you are a musculoskeletal
physiotherapist. Yes.
So what are the other specialties?
Like I said,
how do they function?
All right. Musculoskeletal physiotherapist, is actually a specialty, or let me say subspecialty under physiotherapy. We call it orthopedic physiotherapist. Just like we have neurologic physiotherapy, physiotherapy in cardiorespiratory, physiotherapy in pediatrics.
The one that they do physiotherapy in cardiorespiratory, what do they do?
They manage cardiorespiratory conditions that have to do with disease conditions of the lung and the heart.
What kind of maneuvers do they do?
They rely majorly on exercises.
Okay.
There is what we call respiratory exercises. There are different forms of respiratory exercises, and also exercises to enhance cardiovascular endurance, to train the heart. That was where I was going initially before we went on break.
Okay.
That when we conduct exercises in the gym, we just don't administer exercises anyhow. There are high intensity exercises and low intensity exercises. The low intensity exercises most of the time targets the heart, the cardiorespiratory endurance. You want to start from low intensity and build it up,
okay,
till the patient is able to take more and higher intensity.
Okay.
That's why the issue of where aerobics come in.
Aerobics, yes.
Yeah, aerobics is an interesting area in physiotherapy.
And I think they have a lot of monitors around them, you know, when they are doing it for them.
Exactly, especially for those with underlying pathologies.
Yes.
Take, for instance, hypertensive patients, diabetic patients. You just don't want to subject them to exercises anyhow. You just need to monitor them and see how they are doing.
So that's cardiovascular.
Exactly.
Physiotherapy. Yes, which other ones?
Yes, I've spoken about
how about
pediatric
people who have contractures? Is there any form of exercises after burns injury?
Yes, contracture.
Or some form of... is there anything that can be done to people who have survived burns injury, extensive burn injuries, and there's some degree of loss of function and all that?
Okay, I have an issue with that.
Okay.
Actually, just sincerely from experience, I discovered that most cases of burn are not promptly referred to physiotherapy. So perhaps...
And they should.
And they should.
How early, please?
As soon as it happens.
Okay.
Because right from the onset of the injury, contracture is bound to set in. And we don't want to manage contracture in burns.
We want to prevent
it. So that is why it's always advisable.
What are you people going to do? Sorry?
Positioning.
Okay.
You see, even in the hospital with our colleagues in other healthcare professions, the impression is always that physiotherapy is always about aggression. There is nothing aggressive about physiotherapy. That is the reality. So ordinary positioning is not ordinary. It will help in achieving and preventing a lot of deformity in the long run. For instance, you mentioned burns. People with burns injury, we want to ensure that the body parts, the joints are positioned well in such a way that contracture will not set in eventually. Take, for instance, someone with burns in the upper limb. You want to ensure that the hand is extended at every point in time in order to prevent contracture. Because the tissues.
Yes. Because you will see that the way some burns injury here, it's more of some form of something hanging it from here to here.
Exactly.
You know, which is the failure of the, you know, of that exercise and that awareness.
Exactly.
When the patient is being nursed.
Exactly.
You know.
So that's why it's very important. We, apart from positioning, we make sure we move the joints regularly.
Yeah.
If the joints are moved regularly and they are adequately positioned, the chances of such patients coming out with minimal or no deformity is very, very high, especially contracture. All right.
So with this your field, how many of you are in this state? Like in your state hospital, how many of you are there?
State hospital?
Yes.
Okay, let me say myself and my HOD. Though we do have a lot of interns and
coming around.
Core members that we work together.
Augment your services.
Yes.
So for the future of physiotherapy in Nigeria, what do you think? How do you see the future?
Like I said, it is an evolving profession. It started from somewhere. Physiotherapy started as a diploma training. And to the glory of God today, it has evolved into a 6-year program
in the university.
Where students graduate with a Doctor of Physiotherapy.
Oh, now?
Yes. And from there...
Even in Nigeria here?
Yeah, even in Nigeria.
Okay, in Ife?
No, it has not started in Ife. Okay. I'm aware of the University of Lagos. It has started in University of Lagos.
Okay.
I There's this school I'm trying to remember in Ilorin.
What gave birth to the doctorate? Is it being a doctor? Is it because of the number of years or the syllabus or something? Is it equivalent to masters?
No, it's not equivalent to masters. It's still a first degree program. It's still a first degree.
Okay.
That is not even up to masters, but the curriculum has been upgraded upon. It has been upgraded.
Yeah.
So it's not just unlike when it was a 5-year program or a 4-year program.
Yeah.
So, and with DPT, we talk of curriculum upgrading. They are trained in such a way as to diagnose independently and refer patients promptly when condition demands for it. And pharmacology is even being integrated into physiotherapy training.
Okay.
So there are some conditions where physiotherapists, even though physiotherapists in Nigeria are not licensed to prescribe drug prescription, no. But in some other countries, take for instance UK, physiotherapists are licensed to prescribe some medications, not just all medications, just some medications.
That's fine. Thank you, Mr. KAYODE FOLORUNSO.
Thank you very much.
We viewers at home, we've had the privilege of speaking with Mr. KAYODE FOLORUNSO, who is the Chief Physiotherapist, State Specialist Hospital, OSOGBO. I think we have a few takeaways. So what is your parting message? What do you want people to know about your field and how people can be benefited?
All right. Talking about physiotherapy, I said at the beginning that treatments involve using physical method, physical means in attending to patients, in rehabilitating them. So I want to tell viewers at home that when it comes to managing conditions, that it is not in all conditions that is all about taking medications and medications alone. There are also other things that could be done in assisting patient conditions when they come to the hospital. And physical care is one of them. And we have various modalities which we use in delivering our treatment. We rely a lot on exercises. We rely on temperature differences, both heat and cold.
Oh, in what conditions do you use heat?
You know, heat promotes healing.
Oh, yeah.
So any injury to the body, we want to use heat to promote healing. But that is at the subacute and chronic stage.
Yeah.
So what do I mean by that? Imagine somebody sustaining ankle injury at home now. Most of the time, the common practice is to try and get hot balms. I don't want to mention names now. To get hot balms and
one very muscular man.
Hot pack, and apply hot water, then with aggressive massage onto that injured bar. But the reality on ground is that we do more harm than good. When that happens, ice is better, and send the patient for physiotherapy.
Thank you, Mr. KAYODE FOLORUNSO.
Thank you very much.
It's been a pleasure having you on this program. I'm
pleasure,
sure our viewers at home have benefited. This is Spring Clinic, always coming your way every Monday, 3 o'clock. Hope to see you next week by God's grace. Bye. My name is Dr. Yewale Adeoye.